Captain Samuels in the payroll department. I'm the CEO at Founders Community Bank. About 4 months ago, almost 4 months ago, I had an event at home in which my heart stopped. I was very sick. I didn't know I was very sick. I had double pneumonia. I guess I had it for several days. It led to several other complications like blood sepsis, very high fever. One night at home, I got up apparently to go to the bathroom, and I went down, like I said, because my heart had stopped. No blockages, anything like that, just got overtaxed, and I was toast. Now, I tell you that quick backstory because in my personal opinion, if my wife had not already been trained in ends-only CPR, I wouldn't be here today talking to you. She knew exactly what to do, made the phone call to roll the crews that took care of me. I think you told me that took about 8 minutes time from when I went down.
8 to 10 minutes.
And let's face it, you know, in that span of time, I would guess most spouses would just look at their spouse going, I'm not sure what to do, and let you lay there. And that span of time, with nothing done, mentally at least, probably overall, you would not survive something like that. So, all that being said, I'm awfully happy she was trained and knew what to do for me. Like I said, I wouldn't be here. So, all of that being said, I'll turn it over to you. Why don't you take a deep breath and speak a little bit.
I know we're all among friends, but I'm used to just talking to a few of you at a time. This is a little overwhelming for me. But as Tom said, he was sick, but he is very stubborn too. And we've been married for over 30 years, and he has a history of asthma and hay fever. So when he was sick on Monday and Tuesday, and I asked him to stay home, there was always something he needed to go do at work. And so finally, on Wednesday morning, May 1st, I said, do you really have to go to work? And he said, no. Well, no, he said yes, but I only have one meeting. When I get done, I'll come home. So he came home, but and then I came home because we were going to be leaving for the weekend, and I wanted to do some things. And he goes, you know what? Can you stop and get me some more Advil? I'm out of Advil and Gatorade and Propel, so I'll stop at the store. Came home and touched his forehead and said, yeah, you have a fever, and are you okay? He goes, yeah, I'm fine. Go ahead. So left, but then we fast forward, and I made your husband's sick, you get chicken soup. So I made chicken soup, gave him a couple more Advil, and in the middle of the night, around 3:30 in the morning, our dog Stella, she came in, and he sat up and he said, I don't feel right. Can you give me a couple more Advil? And I said, sure. So I went to give him some Advil. In the meantime, I'm taking Stella out to go outside, and then I come back and he's still sitting up, and he goes, I don't feel right. And he goes, I'm going to get up to go to the bathroom. You may need to help me. And as he's saying that, and I look at him, I said, you need help? And he collapsed. And so I think, thank goodness, he collapsed not on the bed, but on our carpet on the bedroom. And he was lying on his back. And I thought, well, that's good. So I did the shake and shout, and nothing. And just to make sure, I did it a second time, and a little more strongly. And
apparently slapped you in the face,
well,
too.
yeah, I did. I was going to skip over that part.
I remember. Weeks later, I remember.
So when the shake and shout didn't work, I thought, well, I got to get help on the way. So I jumped over the bed, and because the phone is always on my side of the bed, and so I called 911, and I explained to Medcom what happened, and they give you a series of questions, and then they said they were going to have the crew rolling, and I said, quiet arrival, please. And so they were coming, and then I said something about can you please tell the crew it's payroll Kathy, because I thought I want them to know they're coming to see somebody that they kind of know. And then the dispatcher says, do you know CPR? And up until then, it was just like, okay, gotta get help. I don't know what to do. But then she says, do you know CPR? And I said, yes. And that was so calming and empowering to me that now I know what to do. Besides getting help on the way, now I have a role. I could do something between just sitting him lying there and not waking up from the shake and shout and slapping, and until San Luis Ambulance and CAL FIRE got out to where we lived. Because I'm looking at the clock and I said, okay, it's 3:38. It's going to take a couple minutes, and these minutes are important. And when the dispatcher said, do you know CPR, then I kind of went into the training mode and saying, okay, I have a cordless. To do proper CPR, I'm going to put my phone down by my knees. You'll hear me count. And at that time, what I remember doing is 30 and 2. And I know it's hands only right now, and I will do hands only. But for me, the 30 and 2 really worked, because after 30 really hard thrusts, I was tired. And I kind of look forward to getting to the 2 breaths. For me, that's what you do, but for me. And it was a deep breath, and it's just like, okay. And then, because, you know, I'm pushing, and I recall 13 years ago when I was first certified in CPR, and I asked the instructor, how do you know when you're doing it hard enough? And he said, you can't do it hard enough. If you do it well, you'll maybe break a rib or two, but very successful CPR is when the person comes back and complains that their chest hurts. And
no idea it hurts.
yeah. So I'm here to say you never know when you're going to need CPR. I am just so lucky, grateful, blessed that my employer, San Luis Ambulance, not only has everybody in the field, but everyone who works for San Luis Ambulance is CPR. And now Tom, where he works, he's going to have everyone get hands only. Is going to be CPR. And have your loved ones, have your friends, have your neighbors. You just never know, because I never knew 13 years ago, and then being recertified, that in the middle of the night, that 2 Advil calling me in the morning was not going to work, because that was his idea. But,
and I have to add too, I was certified over 30 years ago, the old fashioned stuff, but I haven't been recertified. I've done nothing. Roles have been reversed. If she had been the one that had gone down at home, I would have panicked, I'm sure. She was very calm because of a lot of people like yourselves in the process that helped her keep me around long enough until everybody else said to take over. It's a great tool. Everybody should know it. Spread the word. We certainly will.
Yeah. And this is something cheesy, and Tom says, I can't believe you're going to end with this, but I am going to end with this. In the word team, it started off with me, but when my world got turned upside down, we, because the entity flipped upside down, it's we make a difference. So this team here is a wonderful team, and if all of us can just walk away today and train one person, or maybe 2, then that's paying it forward. And you just never know when a friend, a loved one, a neighbor, or just a bystander will need what we do. Because once when Tom was at the hospital, and a lot of people came up and said, oh, you know what, you rock, you're a hero and everything, and I just kind of said, you know what, no big deal. And then several days later, because we were at French Hospital for 19 days, 11 of them at ICU, but on May 5th, there was a bicyclist who had a cardiac event, and there was several other bicyclists with him. And one of the nurses came down, and she had tears in her eyes, and she goes, I keep on hearing you just saying it's no big deal. What you did was a big deal, because somebody is lying in our ER because they kept on saying, you know, you do not realize the bystanders, they just stand there because they don't know. But knowing what to do is empowering. So I empower you to share what your knowledge is, to share with other people, because 2 hands can make a difference.
want to know, for me, and to understand that you're a symbol, you know, along with all our, you know, the people that we do get to save, a symbol for us that with, you know, the EMS coming together, you know, I'm not just talking about a medic or an ambulance or a fire, I'm talking about the whole EMS system. When we come together and we do what we're trained and we do it right and we do it as a team, this is the result. This is the end result. And Tom, you're like a symbol, and I'm so happy that you're here, you know, to prove to you guys, yes, it, you know, it does work. Of course, we do come up to situations where they're unfortunate, like the bicyclists, but no, that's what you mean to us, to me at least. So, thank you for coming to share your story. With that, Kathy, do you have, Jess, do you have anything
Do you want to talk a little bit about the CPR study?
Well, I don't know if I can follow that. Other than to, those of you that have seen the first 6 months of data that we've been able to acquire and put together and look at, really re-emphasizes the message that was just given. And if, from a statistical and data standpoint, if you really look at it, when we look at our cardiac arrest for the first 6 months, we responded to 52, I think, of them that were transported to a hospital. Of those that we worked on, 40% made it to the hospital with a return of circulation of some sort. But of those that walked out of the hospital, we have 13%. And if you look at those that walked out of the hospital, or came out of the hospital, 75% of those had pre-arrival, pre-EMS CPR, which re-emphasizes the value of the first step in the chain of survival of early dispatch, early notification, bystander CPR, and then the electricity. And then we look further down, we wanted to see, well, how many of those did the first responders apply the AED, was the AED used? And 50% of those patients had the AED used. So the whole process that we're kind of talking about today feeds into the whole system. And I think it was nice to see the study and what we're doing here. We're doing good. We're kind of national average. But if you look at programs that have a really robust citizen CPR program, a robust AED program, their numbers are a lot better than this, and that's our goal, our work towards that. If there's any specific questions on the information that I sent out, I'm certainly happy to answer that. What you guys can continue to do to help us get this information is rather, we pull it from a lot of different places. We get it from our first responders, we get it from our PCRs, we get it from hospitals. Everyone has been very, very gracious in supplying those. Documentation, anytime you can document on your PCRs or your pre-hospital information, whether CPR was done, AEDs were used, whether they were applied, it makes our job of investigating and pulling the data just a little bit easier. So I appreciate that.
And like you said, there's so many elements to make our system work. One of the biggest things I'm a huge believer in, I've been a part of for about 7 years as a CPR instructor, is public education. You know, that bystander is key for us to get there and make it work. And we did a great job this year. I think we hit our 1 day of teaching CPR. I think we hit our new record, I guess. I don't remember exactly. We hit our new record. What was the how many people we trained?
10,025.
Wow. Yeah, that was significantly higher than last year, the previous years. That is our new goal, and you know, couldn't have done it with the on-duty crews that day teaching CPR. So great job, you guys. And with that, we got everything covered. I'm gonna turn it over to Les and let him tell you what's going on next door. So everybody round of applause for Les.
Good morning, everybody. And first of all, thank you so much for inviting us here. I speak for my team here. This is an honor and a privilege to be here to share what we have learned in Santa Barbara County and see that your county is interested in going in the same direction as we are. And the story that we just heard from Tom and his wife, this is what it's all about. You know, had his wife not known CPR, we know what the end result probably would have been. And that scenario, I think everybody's aware that that scenario plays hundreds of times, if not thousands of times in this country every single day. And unfortunately, most of the time, the end result is not as favorable as it was for Tom, where Tom can go back home and continue to pay his taxes and, you know, live a quality of life. And that's what we want to see. And I can tell you, for Shane and myself, we became excited about this project back in November of 2010, and that's when both of us attended the ECCU conference down in San Diego. Dr. Salvucci, our medical director in Santa Barbara County, was already looking at this. He was very interested, and when he learned that I was going down there, he said, I want you to take lots of notes because this is something that we're probably going to be moving forward in the near future. And we all know in EMS, it doesn't, you know, you can't just turn things around on a dime. It takes a while. There's a lot of things that have to, you know, go into place, the research and everything else. And certainly with Dr. Salvucci, with the evidence-based medicine, as Dr. Renee, we need to make sure that it's something that is definitely going to make a difference. And what Shane and I saw when we were down at ECCU conference was, wow, this is something that makes a difference. And it's something that myself as a paramedic for a long period of time in my life, how many times have we made changes? And oftentimes it seems like we're making changes just for change's sake. And then we go back to something else because that didn't work. And this time it was like, okay, I think we've really got something here. So with all of that, we're going to start with our presentation here. And what we're going to show you here this morning is essentially the PowerPoint presentation that we've used to train all of the crews in Santa Barbara County. Arrest management, take crew resuscitation. We've got some numbers there, 33, 48, 55, 37, and 60. What do you think those numbers represent? PTO time? Okay, those, when we first started this project and we were putting everything together, in Santa Barbara County, I look at every cardiac arrest call that happens. In a 3-month time span, those were patients' ages that had suffered sudden cardiac arrest and been in ventricular fibrillation. Those are young. You know, these are not 80, 90-year-old people. These are pretty young people. And the older we get, the younger those ages are. They're babies. Well, and unfortunately, all of them died. You know, the outcome wasn't good. And on all of these cases, okay, there was no bystander CPR. It took a while to get on scene. Defibrillation took a while. And it was just the whole process. And it's not that we were doing anything wrong, per se. It's just that we've been doing things differently. And we need to change the way that we run our cardiac arrest call. So that's what we've been working on in Santa Barbara County. So our goal is to maximize the number of cardiac arrest patients that wake up and return home to their families, such as Tom. And if we can do that on more of our cases, then we're doing our job. So you might hear the saying, some of you may have already heard this, that it takes a village to achieve our goals. What we mean by that is not just your paramedics and your EMTs, your ambulance company, your firefighters. It's everybody has to make this change. First of all, it's that community recognition, okay, as Tom and his wife were talking about, is getting them to understand how important it is for them to get involved. That if somebody collapses from sudden cardiac arrest, how to recognize that that person has actually suffered sudden cardiac arrest and what to do. And that we don't have to do the mouth-to-mouth resuscitation anymore. It's the hard and fast compressions on the chest. So that's part of the process there. And then it's the dispatch, okay? Calling 911 and making sure that your dispatchers are very aware and suspicious of somebody that has suffered sudden cardiac arrest and providing the proper EMD instructions. I saw that. I had a privilege to go up to Seattle last October and go through the Resuscitation Academy that Medic One puts on. And we look at Seattle and say, that's who we want to be. Okay, Seattle's so far above all of this, it's ridiculous. But you know what? They started this a long time ago, and that's a great goal for all of us to look at, trying to achieve. But their dispatchers, they're much more aggressive on their calls than I think a lot of dispatchers, at least the radio reports that I've heard. If it's not breathing normally, if the patient is not breathing normally, they don't ask if the patient's breathing. Because so oftentimes you'll hear that person that suffered sudden cardiac arrest, that they're gasping. Well, for the lay person and oftentimes for the paramedic, okay, they're breathing, but they're not breathing. They are not breathing at all. This person is probably in VF, and we need to start hard and fast compressions, and that's what they do. That's part of the equation why they have a success up there that's much better than most other parts of the country. EMS response, that's us. Okay? Obviously get in there quick and fast, and then how we perform while we're on scene. And then, once we resuscitate them and getting them to the hospital, okay? Getting them to the right hospital. What we did in Santa Barbara County, we changed our destinations. Is our patients, if we're in Lompoc, where we have Lompoc Hospital, we run a cardiac arrest, and we achieve ROSC, a return of spontaneous circulation, we're not going to take them to Lompoc Hospital. We're going to take them to Marion Hospital, because that's a STEMI receiving center. It's a longer trip, but this is ultimately what's going to save their life. Having that hospital start therapeutic hypothermia, okay? The research out there and the evidence is showing that therapeutic hypothermia is definitely good for this patient that suffers sudden cardiac arrest. We're fortunate in our county that Dr. Salgucci has allowed us to start pre-hospital therapeutic hypothermia on our VF patients where we have attained ROSC. And not a lot of that's been done in the country yet. We don't know what exactly, are we really doing, the patient good with this? We're not sure yet, but we know that it's definitely not in the opposite. It's not poor for the patient. Okay, so some of the strategies. Okay, assign a defined role. Okay, this is all about teamwork, rapid and accurate assessment. Having an adequate workspace, and we're going to go through these each one by one here pretty soon. Continuous high-quality chest compressions, that's our key. Prompt defibrillation, airway and synchronized ventilation. And then with the ALS, you can see how far down the list ALS gets. Is our vascular access with medications and emphasis, double emphasis on teamwork. If we're not working as a team, then we're not going to be successful out there. Recognizing that the patient has achieved ROSC, and then our post-resuscitation care. So we've got to go back to the basics. And what I mean by that is our cornerstones of treatment is doing our proper patient assessment, and then patient positioning, high-performance CPR, which encompasses continuous chest compressions, and then airway ventilation / oxygen, and then early defibrillation. Okay. Some of the things that are proven or possible, but not necessarily proven, is intubation. Well, we'll get more into that in a little while, what we'll do in Santa Barbara County. Our vascular access, our pressors, and our antiarrhythmias. So, success throughout the country. Seattle, in 2011, they had a banner year. Their sudden cardiac arrests that were in VFib, okay, 56% of their patients, that wasn't ROSC, those were patients that walked out of the hospital neurologically intact, either with what we call the CPC 1 or 2. CPC is a cerebral performance category. CPC 1 is our baseline. Okay? And obviously that's what we want to achieve, is to get somebody back to who they were before they suffered cardiac arrest. A CPC 2, they've got some minor neurodeficits. Maybe they have a slight speech impediment. Maybe their memory isn't what it used to be. But for the most part, they can go back home and they can resume a normal life for all intents and purposes. And 56% of their patients that suffered sudden cardiac arrest went home as a CPC 1 or a CPC 2. I don't know, that's pretty amazing. And their goal, they want to hit 75%. And knowing Seattle, they just may do it. Austin, Texas, 46%. Again, amazing. Okay. Rochester, Minnesota, 45%. Glendale, Arizona, 45%. And there's Santa Barbara, okay? This is 2011, 14%. Okay, as Kathy just said, yes?
I don't know if you have any questions, but did you preface these statistics with their rhythm? Did you say
These are all VF.
These are all VF.
Yeah. Yes. Thank you, Brooke. Make me clarify that. So, however, and I will tell you, and this is something that we have seen in Santa Barbara County, because I'd heard stories about patients that were asystolic or in a PEA rhythm when the paramedics got on scene, and being able to be resuscitated into a CPC2 or maybe a CPC3, which is a little bit more neurologically, yes ma'am.
Is this the baseline from the VFib patients or the VFib with Ross?
This is your VFib patients, okay? Strictly V from when they get on scene. Because in Seattle, a VFib patient is a survivable patient. It's kind of like your hypoglycemic patient or your opiate overdose patient. I give them a little Narcan, I give them a little dextrose, they're going to sign out AMA. Okay, we haven't quite got to where our cardiac arrest is sign out AMA yet, right? But that's their mind thinking, is when they get a patient that's in VF, we are going to get Ross back. Not only are we going to get Ross back, but this patient is going to leave that hospital and resume a normal life. So Santa Barbara, 14%, pretty much what the country is doing. Our goal is for this year, 2013 is going to be the first year where we're actually going to be doing PIC Crew pretty much through the entire year since we began in October, is we hope to see that double, if not triple. And as I was mentioning, PEA and asystolic patients, we had heard stories where somebody was in a rhythm such as this, and you don't expect them to survive. We have had 3 cases now where a patient was in either asystole or PEA that we've not only got Ross back, but they've actually survived. Now, the one PEA patient actually ended up with a CPC score of 2, which is amazing. And the asystolic patients, a CPC score of 3. Typically, a CPC score of 3, their neurodeficits are such where they probably need some help. But oftentimes they can go home. The one that we want to avoid is a CPC score of 4. That's the person that's essentially in a vegetative state. None of us want to be like that. That's San Luis County. Now I've heard what you are is 13%. So we all have some goals to work on. So our prime directive, continuous, high-quality chest compressions will be performed from the moment of this cardiac arrest until we have a return of spontaneous circulation. I've got this slide up here, CPR through the ages, and some of you guys in here may remember when we did it this way. Okay? We have tried a lot of different things throughout our careers and throughout the history of EMS. And how do we resuscitate somebody that's suffered sudden cardiac arrest? And for those of you that have been in this field for any length of time, like me as a paramedic, it's like, okay, we do the best we can. It was all about my intubation, my paddles, our stacked shocks. We do, it was almost about us rather than about the patient. And I look back at those that I was fortunate enough to be involved with that they actually did survive. It's like, wow, how did that happen? Wow, really? He survived? Man, we did something right. But you look back and say, okay, the common denominator was somebody was performing CPR before we got there. And I think that's something that, if anything, we all take home from this today, is no matter how good we get at performing, okay, if it's taken us 5 or greater minutes to get on scene, if nobody's doing anything, okay, if Tom had not gotten any CPR from his wife, we all know that the end result would not have been the same. And so that's why it's so important to get our community involved in it. But I've got this here is because we've seen all these changes. Most of the time, changes don't really seem to make much of a difference. But this time, we've got something. Okay? I firmly believe that 100%. I think my whole team that's here from Santa Barbara County believe that 100%. Because we got something that we can make a difference and see a lot more people survive sudden cardiac arrest. So I'll get into this a little bit more. Actually, Shane will. This is kind of our roles that we use for our triangle of life that we have in Santa Barbara County. We have rescuer 1, 2, 3, 4, and then additional resources or additional rescuers as we get on scene. And those are those assigned roles that we have. So our number 2 strategy, we recognize that somebody is in cardiac arrest. Okay? We do a rapid assessment. Okay? Are they responsive? We've shouted, and we open their airway after unresponsive, and we use a new method called the shark hook. Okay, and we'll show that to you. Okay, this is a shark hook method is something that was devised by Dr. Dan Davis. I don't know how many of you are familiar with Dr. Dan Davis. He is definitely plays a huge part in this. He's down in San Diego, and Dr. Salvucci, and I believe Dr. Renee, support a lot of the research that he's been doing. So we use a shark hook to see if we can elicit respiration from this guy if he has just an occluded airway. If not, if they're breathing, okay, if there's no breathing, or as I said before, agonal breathing. If it's not normal breathing, we get right on the chest. We don't check a pulse. And mind you, these are ones that we're suspicious of a cardiac arrest. Somebody that's got a needle sticking in their arm or a bullet hole in their head. These are medically cardiac arrest. And we start our compressions right away. So this is the shark hook. And what that is essentially taking your index finger, sticking it in the tissue right here underneath the bony prominence of the chin, and lifting straight up. Shane will show you a little later on when we do a demonstration here. Then number 3, our patient positioning. There's no way that we're going to run an efficient cardiac arrest call if we're inside a closet or a bathroom, or some small hallway somewhere. And we probably have tried to do that sometimes because, it's going to take us quite a while to drag them down the hallway and get to that living room or something like that. Well, we need to change that if that's the way you have been doing it, because we need to have enough room where 3 to 5 rescuers can work efficiently on this patient. So if it takes you 30, 45 seconds, maybe even 60 seconds to get this person into an area where you can really work efficiently on them, that's going to be time well spent, because you're going to be able to perform at a much higher level, and you're going to give this person a much better chance to survive sudden cardiac arrest. Our chest compressions. Strategy number 4. This is the meat and potatoes. It's continuous, high-quality chest compressions. We stay on the chest as much as we possibly can. Our rate in Santa Barbara County is 110 compressions a minute. That's optimally what we feel is what we want. The depth, at least 2 inches. And it's interesting, some of the studies now, they're starting to say 2.6 inches. In Europe, there's a lot of areas in Europe where they want you to go 3 inches. Obviously, if you've got somebody that weighs 90 pounds and thin and frail, 3 inches isn't going to be reasonable. But on a lot of our, bigger adults, average adults, 2.5 inches, even 3 inches is much more appropriate. And then what is key is recoil, getting fully off the chest. And when we started practicing this, I realized for myself, this was one of the things that I had been horrible at both as an EMT and as a paramedic. Because my CPR wasn't very good. I thought it was pretty good, right? But it wasn't, and mostly because, number 1, I wasn't going as deep as I should, and number 2, my recoil. I would stay right on the chest with my hands. And we have to get off the chest because that's what allows the heart to have that return of blood. So, perfusing the heart and brain by the right rate, the right depth, and full recoil. And this is going to increase the likelihood of a successful defibrillation. Great video presentation that came from Sweden on a pig's heart, where they would induce this pig's heart into VF. They would not do any CPR whatsoever, and then they would shock it and would go right into a systole. No CPR, shock it right into a systole. And then they would do cardiac massage, and then they would shock it, and boom, right into a perfusing rhythm. And this research showed us that shocking an empty heart does us no good. We're not going to get that perfusing rhythm. We have to have a heart that's full of blood in order to have a better chance to convert this patient from VF into a rhythm that hopefully is going to be survivable. And one of the mantras that we took from the Resuscitation Academy in Seattle was, when you're doing your compressions, is thinking brain, heart, because when I'm pushing down on that chest, okay, we're perfusing the brain. And when we're coming up off the chest, that heart is refilling and we're perfusing the heart. So it's brain, heart, brain, heart. And if you think about it, if somebody that's in cardiac arrest, okay, they don't need as much oxygen. And about 25% as much oxygen as they would if they were typically breathing. Okay? So that's why we focus on the chest compressions. However, that being said, if you're doing really good compressions on that recoil, you're actually going to get as much as 200 cc's of oxygen into the lungs just by adequate recoil. So here's a pretty good graph. Normal or standard CPR versus continuous chest compression CPR. What a difference there is in preserving the brain by just staying on the chest completely. So we got this graph here, or this picture of this guy in a proper position for doing CPR, shoulders directly over the patient, knees touching arm. The reason that we have that is when we've done our CPR training, so oftentimes we see people that are not in a proper position. And if you're not in the proper position, if you've got your arms bent or you're too far away from the patient, number one, you can hurt yourself, okay? It's going to hurt your back. Number two, your CPR is not going to be effective. And number three, it's not going to do the patient any good if you're not having effective CPR. So it's really, really important that when you're doing your CPR, do it the right way. So here's a graph for our quality compression rate. Well, they had found through the studies with Dr. Dan Davis, Dr. Salvucci, and some of the other physicians out there, that 110 to 120 are the optimal rate of compressions that we want. If we're going too slow, we're not going to generate enough force to actually perfuse the brain with blood. If we're going too fast, you're not allowing the heart to refill with blood. We do CPR reports in Santa Barbara that I'm able to look at. And for quite a while, I thought the record was going to be 187 compressions a minute. I thought that was pretty impressive. And obviously, that's not going to do the patient any good, but we just recently broke that record with a 207. Yeah, that's impressive. I'm impressed that somebody could actually do compressions at 207 a minute, but unfortunately, you know, this is not going to do our patient any good.
That's that fast.
So that, again, there's the recoil. And we try to teach people a little bit different way to do CPR by keeping their fingers on the chest, but allowing the palm just to come slightly off the chest, about enough for a credit card to slide under there. Just allows that chest to return to zero and refill the heart with blood. I love this graph. And let's see if I got a thing here. If you take a look at the little, see the aortic pressure down here where there was no CPR, and you can see how it's bottomed out. And then start compressions. And we want to get that aortic pressure up. And you can see how long it takes. It takes about 15 to 20 compressions to get that aortic pressure up enough to where it's actually now perfusing the brain. So think about it. We're doing 32 compressions, right? That's what we have learned how to do. So we do our 30 compressions. It took 20 compressions to get to where that blood is starting to flow to the brain. All right, we do 10 more compressions, and then we stop to do 2 ventilations. And if you're doing 2 1-second ventilations, it's probably taking you anywhere from 5 to 8 seconds, depending on how fast or how slow you're doing it. Now what's happened is it only takes the heart anywhere from 3 to 5 seconds to completely empty. We now have an empty heart again. And now we start compressions again. And then again, we start all over again. And so that's why it's so important, is that once we start compressions, we just continue our compressions. Here's some common CPR quality issues. Okay, that's our free. This is ventilation. Okay, as AMR's medical director, Dr. Charles Drayson, who's been emergency physician for about 37 years now, he says he probably would be considered as a serial killer for the number of patients he's killed from hyperventilation. And how many of you remember when we get on scene, okay, hyperventilate, especially right before you ventilate, go ahead and hyperventilate my patient. It's the wrong thing to do. We've learned now that that was the wrong thing to do. Shallow compressions, okay, not going deep enough. Well, I'm afraid I might break a rib. Well, I'm sure Tom's okay with having 3 ribs broken, because he's here to talk about it today. And so we have to understand that oftentimes that's what's going to happen. Either having too slow or too fast compressions. That's why, ideally, I tell you, the metronome is the way to go. because that is going to keep just about everybody on time if you have a metronome that's activated. And then incomplete recoil, which I've talked about. So, our compression key points. Correct rescuer body position. Press fast, 110 per minute is what we do in Santa Barbara County. Press in deep at least 2 inches, not 2 inches, but at least 2 inches. Full chest recoil and continuous CPR. Our goal is when we are on scene, we don't want that person to get off the chest, or those people, those rescuers to get off the chest for more than 3 seconds, ever. That's our goal. So defibrillation. This is key. Shane, you want to take over from here?
To change a little bit about the way that we shock. And you're like, what? Really? So, AED use. So the BLS provider. We use this really cool box. Okay? Delivers a shock of some kind. We don't really know, but it gives a shock. The patient moves, and it's cool. But we're going to change the way that we use that box. Okay? Of course, we're always going to give that high-performance CPR. That's what it's all about. The two things that we know that works is CPR and the shocky thing. So let's use it as fast as we can. So we're going to attach that bad boy, again, as fast as we can. Okay? Someone starts CPR, put on the box. Cool. We're going to try to analyze the rhythm, again, as fast as we can. So if we're on top of our game, hopefully the person that's doing compressions is only at like 40, okay, when we're ready to analyze the rhythm. So then it's going to do the little analyze portion. And depending on the AED, it could be up to 30 seconds or so. Okay, so no one's touching the patient. We're like, oh, I don't like that. Don't touch the patient. Shock advice. Awesome, sweet. Okay, we've got a shockable rhythm. That's a good thing. What is next in the cycle of the AED? Well, it's got to charge, right? And usually, we're still not touching the patient. This is where it's going to get a little bit different. During the time that the AED is going to charge, we are going to get back on the chest and do 30 compressions. 30 compressions to get that blood back into the heart so we hopefully can get a more successful shock. That's our goal. So during the time of the AED, when it's charging, analyzing heart rhythm. Do not touch patient. Shock advised. Charging. 30 compressions. Let's go. Let's do it. Stay on the metronome. Cool. Okay, count it out loud. 25, 26, 27, 28, 29, 30. Off the chest. Shock. Boom. Back on the chest. Okay? It's that fast. And you're like, what? Is that dangerous? I don't know. No one got shocked yet. Here's the thing, though. It's all about teamwork. Okay? That AED is going to be just blaring. Shock me. It's beeping. The red button is flashing. You want to hit the shock button. But rescuer 3, oh, don't worry, guys. I got you. 30. Okay, off the chest, clear. Shock delivered. Back on the chest. Cool. All right. The key thing, again, is all about teamwork. The person doing compressions, make sure you count out loud. Rescuer number 3, making sure everybody's clear. And then we deliver the shock and immediately get back on the chest. That's our goal. Now we're going to talk about timekeeping. Timekeeping seems to be the biggest thing. Because if the timekeeping actually works, man, does it so cool for rescuer number 4. Because they're just sitting around just, okay, I guess I'll talk to family maybe. You guys good? Okay. So compressors are going to count out each 10th compression. This is super important, okay? Because we're doing non-stop compressions. But every 10th compression, we got to give a ventilation. We're going to talk about ventilations here in a little bit. But every 10th upstroke, we're going to give a little bit of ventilation. We're going to show you what that looks like. Rescuer 3. Again, I'm going to talk about the roles in a little bit. But Rescuer 3 has a really important job. See, mechanically speaking, Rescuer 3 got an 8. They just got thumb cramps going on. But their hardest job, I like to say, is keeping the team on track. They're the leader, so to speak, of the triangle of life. They're going to tell the paramedic or whoever's running the defibrillator, okay, when it reaches 200. Hey, yo, it's at 200. All right, sweet. Okay. The paramedic will then will go over to the monitor, and we're going to do something that's a little bit different. Again, we're going to pre-charge the monitor. You're like, what? Yeah, we're going to pre-charge it. We go over here, pre-charging the monitor. Don't worry, guys, I won't shock you. Because what do we do when we hear that thing ramping up? Whoa! I'm gone. I'll be like 10 feet away. Man, you're going to get 360 joules of that thing? I ain't touching it. No. Again, we have to work as a team. We have to pre-charge the monitor. So we're going to pre-charge the monitor. Once the monitor is fully charged, okay, they're still going at it. It's still beeping. It's screaming. It's got the blue light button flashing at us. Okay, stand clear. They cleared the chest. You look at the monitor. Is it a shockable rhythm or not? Cool thing about a paramedic is that we can read that pretty fast. Supposed to be fit. Shocking. Shock delivered. Back on the chest. Wow. That is something that when they told me about that, I was like, whoa, why didn't we do that in the first place? Because usually, right, we had to, okay, stand clear of the chest. Okay, defib. Charging. Okay, now shocking. It's a lot of time. A lot of time that the brain is not getting anything. Bad deal. Okay? So again, just a little recap. So we're going at it. We pre-charge the monitor. We clear the chest. defib, shock delivered, back on the chest with the new rescue. Because we got to start CPR immediately. So ventilation. Ventilation has changed a little bit in Santa Barbara County. Of course, we're still going to worry about suctioning the airway. We still got to worry about putting in an OPA. And then the 2 thumbs up method. Again, Rescuer 3 has a very, very easy job when it comes to things, and holding things, and doing things. All they have to do is put their 2 thumbs on top of the mask and lift up the jaw. So all they're doing is sitting there. They're watching their team. They're making sure that they had an adequate airway. That's all they have to do. Rescuer either 1 or 2, depending if they're doing compressions or not. The person that is not doing compressions is the one that is ventilating. We only need 300 cc's. That's all we want. Okay? 200 of which is every time that you push down on the chest. So all we want you to give is 100 cc's. Which you're like, what is that? This thing is like 10, 12, and I usually give like 800. Well, we just want to give that much on the upstroke. You're like, what? This is a problem too, because we get excited during a code. So every time we get an upstroke of 10, we don't want to do this every 10th upstroke. Right? So again, we have to calm ourselves down. Just get 10. Just 100. Boom. 20. 30. 40. 50. I can do that. Pretty simple. Again, every 10th upstroke. So ventilation key points. Good solid grip. Thumbs up technique. Ventilation on the upstroke. Okay, and we want to deliver that about 0.3 seconds. 0.3 seconds. It's pretty quick. Okay, we want to achieve that low volume of no more than 300 cc's every 10th upstroke. So it's every 10th. And then never stop compression. Strategy 7 by the ALS personnel. So ALS kind of takes a back seat. It's all about the BLS crew. Okay? This BLS crew could consist of a medic, but this triangle of life, their dedication is all about CPR. That is their goal. That is their world, is CPR. That's all they think about. They don't have to worry about drugs. They don't have to worry about the tubes. They don't have to worry about anything else except for their world of CPR. But when the medic gets there, the first thing that we want to put on is our in-tunnel CO2 with the BLS airway. Because now that we have a really good seal by rescuer number 3, we can put an end-tidal CO2 on there and actually get a really good reading. We're going to make sure that we switch them over to our monitor so that we can do that rapid defibrillation, okay, that rapid view, rapid defibrillation. And then we have all the time in the world to get our vascular access, either IV or IO. Because now that we have this triangle of life, I don't want to move them at all. They're dialed. They're set in their own world. I don't want to mess with them. So if I can't get a peripheral IV, well, that's okay. I got a gun. I got an IO. Sweet. I'm out of your world. Quick. Easy. Medication. Well, yeah, we still got some of those. We got to get some of those. We got epi. And we don't even know how that works. That's like a standard of care. We don't know how it works. But we're going to get it. We got Lido. Okay. Hopefully we're going to be fit. We're going to get some lidocaine. And then the last thing that we're going to worry about is that advanced airway. Because if I got a good BLS airway, I'm going to keep it. My team is set. If I have a problem with it, oh yeah, I'm going to fix it. We're going to get that too. But only if it needs to be fixed. Okay? It's one less thing for me to worry about. Because the studies have shown that if I try to give that advanced airway, CPR takes a back seat. Because it's still the mentality of, hey, it's all about the tube. It's all about the tube. We got to get the tube, we got to get the tube, we got to get the tube. I want to get the tube. No. Okay, BLS airway's good? Sweet. Let's keep it. Okay? Once we get ROS, oh yeah, that's when I'm going to get my tube. I got all the time in the world. I want to secure a patent airway. Let's get it. Strategy 8 is teamwork. The biggest thing that we need to work on together. If this thing is going to work, we all got to play really good together. Okay? So we have to know our role. We have to know our role walking in the door. Hey, if this is the code today, I'm walking in as rescuer 1, don't worry, I know my role. I'm going to do a little shark hook action. Okay? We have to assume the proper position. Remember, we can't do this thing in a bathroom. Continuous chest compression, synchronized ventilation, making sure that we switch every 2 minutes. That is mandatory. Mandatory switching every 2 minutes. How many times have you been on a code where someone's going at it and you're like, dude, I'm good. I'm good. All right, sweet. Dude, are you good? Yeah, I'm good. You're like on minute 10. Studies have shown. I've seen it on our cool little tool here, this Ambu SmartMan, is that 3 minutes, no one's doing really good compressions. You can talk to me, you can try to convince me. I'll tell you right now, no one in this room, at 3 minutes, you're doing good CPR on your own. There's no way. Okay? Either your depth's not right, your rate's not right, or you're just not going deep enough. Okay? And I thought myself when I first started this thing, man, I've been doing CPR a long time, I've been teaching this a long time, I'm pretty good with CPR. Man, this thing humbled me. I got like a 30%. And I thought I was doing pretty good. But that metronome really helps out. And that team mentality really helps out. Because again, rescuer number 3, their job is to coach me. They're going to try to coach me to make sure I do a good job with chest compressions. So again, communication on scene or prior to the scene, knowing your role. Now sometimes like Seattle, they do their resuscitation of where they sit in like the engine. If they sit in this seat, they're always going to be rescuer number 2. If they sit in this seat, they're always going to be rescuer number 3, and so on and so forth. Okay? Sometimes they do it off a title. Okay? The captain is always at the head. The firefighter is always rescuer number 1. It doesn't matter how it happens, as long as it happens. Okay? We're trying to get away from like title and more of where positioned you are. Rescuer number 1, your role is this. Rescuer number 2, your role is this. Rescuer number 3, you are team leader. Even though that Les outranks me, if I'm at number 3, I'm telling him what to do. And he's like, all right, Shane, sweet. You want me to go a little deeper? Yeah. Okay. So on-scene coaching and feedback is really, really important. Now, I'm not saying like, dude, you suck. Like, get on it. No, it's positive feedback. Hey, I just need you to go a little deeper. hey, remember to come off the chest. Okay? Remember that recoil. You're not coming off the chest. Okay? So again, rescue number 3 has a very, very important role. Again, make sure you switch every 2 minutes. Okay? It shouldn't take less than 2 seconds. This comes into a little bit of a training thing because we have 3 seconds to analyze, either dump the charge or shock in less than 3 seconds. During the time of the analyzation process, that is the time where the compressors need to switch. So they only have 3 seconds to do that. Remember these things. Do not stop chest compressions for ventilation, charging the defibrillator, or any ALS procedure. You don't need to. If you want to get your feet, get it. But you have to do it with self-protection. We all know that the worst CPR that we can do is in the back of an ambulance. Yeah, I got it. Don't worry, I got it. Okay? Doing some acrobatic moves in the back of an ambulance. So we want to try, our goal is to try to get locked on scene. So, when ELS providers stop chest compression, is the only time is when the AED analyzes, when they deliver the shock, when they need to log roll, when signs of life. So when they sit up and they slap you in the face, that's when we can stop. Okay? ALS is going to stop for a couple of things. When they just analyze the rhythm. When they do a log roll, deliver shock, and to perform a pulse check. Hopefully, we're going to stop when we get rocked, like speed. Strategy 9 for rock. Okay? So the job is not done once we got rocked. A lot of the time is that people are like, yeah, we got pulses back. Sweet, let's go. No, we still got some work to do. So, a good thing about Impidal is that it's a tool. It's a tool to help us. It's a tool sometimes to help us declare death. If we have an Impidal and we're doing really good CPR and we got an Impidal of 5, we know that that person's probably not surviving. We got a spike in Impidal CO2. Sweet. Well, I'm going to wait for my next rhythm check. Because chances are, if I got a spike in CO2, Impidal CO2, there's a good chance I have a pulse. Awesome. Well, next rhythm check, we're going to make sure we check the pulse, hopefully it's on a good rhythm. And then, the other thing that we need to worry about is that when we get to organized rhythm, we dump the charge real quick, organized rhythm, is it greater than 40? If it's not greater than 40, we don't even care. We don't even check the pulse. We go directly into CPR for another 2 minutes. We feel that the heart is just not ready enough to get started again. So, bradycardia less than 40, 2 more minutes of CPR. Hopefully the next rhythm check is a good, solid rhythm. And every time I've done this in the field, that's what's happened to me. And the next 2 minutes, we got a nice, strong pulse. Okay, so it does work. Again, we don't want to check a pulse no more than 3 seconds. So this is a very coordinated effort. Check the rhythm. Organized rhythm. Check pulse. No pulse doesn't matter. Go back to CPR. It's just that fast. Okay. And again, if there is a pulse, we're going to go back to our old way of doing things because we want to give that 500 cc's over 1 second at a rate of 10 to 12. Okay, rescue breathing if they're not breathing that way. Again, Ross, want to make sure that the carotid pulse is no more than less than 40. The end-tidal CO2, if it's less than 20, we're going to continue CPR for another 2 minutes. So rescuer 1, this is when the rolls come in. So Pat here in a little bit, he's gonna show you what rescuer 1 does. Okay, rescuer 1 again has a pretty important job. They walk in the room, they presume it's a cardiac event, they get in there, they shake and shout, they do the shark hook, boom. Are they breathing? Do they take a breath? No breath. Sweet. Let's get on the chest. They start this bad boy off in a blaze of glory. Rescue number 2. They have to activate this bad boy. Metronome. And you're like, really? I got to listen to this thing for 20 minutes? Yes, you do. Okay? This little thing is going to help you immensely. And the only way that we can actually prove that to you is for you to actually get tested on this mannequin without a metronome and then do it with a metronome. The difference will blow your mind. But rescuer number 2's job is to get either the AED on or the defib pads on immediately. Rescuer number 3. Again, essentially rescuer number 3 has the easiest job mechanically. All they're doing is holding the mask to the face with the 2 thumbs technique and lifting up the jaw. Pretty simple. The hard part of their job is coaching the other 2 rescuers. Because they really have to pay attention to the count. Are they going deep enough? Are they having enough recoil? Are they switching every 2 minutes? Are they communicating to rescuer number 4? Because again, without that team in place, it messes up their time. If you stay on count to the beat of a metronome of 212, because that's what we do it on our metronomes, 212. Or excuse me, 112. It will be 224 compressions to make it 2 minutes. So 224 compressions, 2 minutes has gone by. Well, sweet. Every 2 minutes I need to do a rhythm check. Every 2 minutes we need to switch rescuers. And every 2 minutes I either need to give a drug or not give a drug. So it kind of works out in my favor to keep them on track.
So Shane, excuse me for saying this. So is it 1 and 2 that are just switching back and forth on
Yes.
ventilations and corrections?
You're absolutely correct. The people on the side, here and here, essentially they have the same job, just at different times during the event. If they are not doing compressions, they're giving ventilation. If they are doing compressions, the other person is doing ventilation. Does that make sense? So rescuer 4, that's usually your analog person. They're the person getting the line. They're the person working the monitor. They're the person giving the drugs. I'm going to be real with you guys. The first 5 minutes is still chaotic. Okay, people are doing things. I'm just being real, because that's real life. Here in the clinical setting, we can talk about this and how perfect it is and how everything works so hunky-dory. But usually, first 5 minutes is still chaotic. Things are still happening. It's real life. Okay, we all know this in EMS. But after those 5 minutes, rescuer number 4, they have all day. They're sitting around thinking, what can I do to reverse this thing? Okay, whenever you got 50? Okay. Well, geez. They're really not, they're just thinking, okay? They have a lot of time. Rescuer number 5, okay? Their first 5 minutes is super important for rescuer number 5, but after that, we're like, okay, now what do you want me to do? Oh, I guess I can switch in. You guys tired? Because I can switch in with anybody that's not doing compressions. Dude, my thumbs are killing me. That was our first complaint. Our first complaint was, man, my thumbs really hurt by holding the mask on for 20 minutes. Really? All right, switch out with rescuer number 3. Sweet. Your thumbs hurt? Fix it. So these are our teaching points. Okay. We want to make sure that we know where we'll begin the shift, maybe. Okay? Or maybe as you just walk in the door. Keep your area should be team friendly. We never want to be mean or ignorant or stupid. Okay? Always remove the shirt and place the patient on the floor, of course. Make sure it's in a really nice area. Because we all know that no one really collapses in the middle of the living room in a well-kept room. Well, at least in Santa Maria we don't get that. But here, it's true. We want to make sure that our compressions are at 110. Never interrupt more than 3 seconds. Our metronome is set to 110. Continuous compressions while the AED is being attached and while it's being charged. Ventilations every 10th upstroke, and then manual monitor replaces AED as fast as we can. And then on scene time, no less than 20 minutes on scene. After 20 minutes on scene, this is when we either decide to transport or call it or whatever. Okay, but we have to work the call for a minimum of 20 minutes on scene. EMTs. And you guys, you own CPR. It's all about you. Without you, this thing doesn't work. Again, we want to minimize interruptions. Anytime the CPR is being done, we have to always keep our depth at least 2 inches or more. Ensure proper chest recoil. Rotate every 2 minutes. Designate a timekeeper if you have time and you have the manpower. Okay, and then it's all about hovering over the chest. I know the guys, it sounds weird, but if you do that, it's so much more efficient and it works. Okay? Intubation kind of takes a back seat, but if you want to do it, make sure you do it while CPR is going on. Place an IV or IO during CPR. That's all I have for the presentation. It's going to be our rescuer number 1. He's going to do that quick assessment. He's going to do the shake and shout, just like you learned in the CPR course you learned probably 100,000 years ago. And he's going to make sure that he's giving really good compressions. I want you to notice a couple things when he's doing compressions. Notice that he's coming all the way off the chest. When we teach this, we actually overemphasize compressions. We're like, okay, this is what I want you to do. I want you to come all the way off the chest, just like so. And you're like, what? Yes, we want you to come all the way off the chest. Okay, it's not the American Heart Association where we stay on the chest all the time. We want you to, your palm has to come off the chest. Okay, that way we can assure that you're going to give full recoil to the heart. That's what we want to see. So try to pay attention to that. When Joey gets on scene, we're going to do this really, really slow. The first thing that he's going to do, hopefully in his back pocket, he has a metronome. Okay? If he doesn't have one, all the ambulance that we have in Santa Barbara County have a metronome. Looks just like this. Okay? It's set to 112, even though our county says 110. We like 112. So he's going to turn that on as fast as he can, and then he's going to get the AED on as fast as he can. Okay?
Something I have to add real quick. We're going to be in here for a long time, and if you're a sweaty guy like me, you want to wear a hat. Get as close to the patient as you can, because you're going to be working for a while.
And then the third member, okay, is going to be Les. Les is going to be, again, really, really proactive in coaching his team. Mechanically speaking, again, all he's going to do is hold the mask to the face, lifting up the jaw. Okay, that's all he has to do. And then again, the most important thing is coaching his team. You will see him doing that. Again, the first beginning part of this, Joey has a job. Rescuer 1, Pat has a job. Rescuer 3 now has a job. He's going to be breathing, essentially, if they get there exactly the same time, which that all happens, right? Exactly the same time all 3 crew members get there. If he does, he would put the OPA in and he would ventilate, just again, 100 cc's every 10th upstroke. You will also see the 2 people that are on the side of the patient, they're going to be counting. It's a very important thing. Whoever's doing the compression is going to count every 10th out loud. Okay? So they can count to themselves 1, 10. Okay? However they want to do that. Okay? There's no exact science. Rescuer 2 has a pretty good important job, though, once he's done putting on the AED. He has to make sure that he's on task. Okay? Because once you get up into like the 80s and 90s, 70, 90, 80, okay? Happens. Okay? Happened to me. I can't count past 80. Okay. So, again, he's trying to keep each other on task. Again, rescuer number 3 is the third man in line to keep everybody on task. We are doing this, or simulating this, as a BLS fire department. We understand, and especially in our county, that's not the case in all cases, in all scenarios. There could be a time when just an ambulance gets there first. We only have 1 paramedic and 1 EMT. You could have an engine company that has 1 medic on board and 2 EMTs. You could have a fire company that have 4 people. One of them is a medic and the other 3. There's a whole bunch of different scenarios, and I wish I could show you them all. But this is the basic one that we get to show you. So we'll just keep that in mind. Okay? There are many, many different scenarios out there, and they each have to be taught very specifically, because everybody has a specific role. Everybody cool with that? All right. Let's get this bad boy in there. And then I will show up as the ALS provider, And the first thing that you'll see me do is I'm going to go straight to the rescue number 3. I'm going to ask them, hey, was this a witness arrest? All the good stuff that you would normally ask. The one thing that I need to know right away is, how's the airway? Okay? Do I need to fix it now or later? Okay? And then I can work on my ALS stuff. All right. Pat, sir, take it away.
So we've arrived. Does everybody remember that shark hook thing? So we're addressing the patient. I see nothing. Shark hook, not breathing on his own. Let's go. Let's start CPR.
3 compressions, put my OPA in there. Count louder for me, Patrick.
9, 10. 10.
Okay, good CPR.
9, 10. 9, 10. 8, 9, 10.
Stand clear, it's analyzing.
Notice I'm kind of just hovering over the patient.
I'll take this.
Okay.
Okay, Joy, you hover.
I'll have it. We're doing CPR.
Okay. 30 compressions. Everybody clear? Give me your last 5 out loud.
26, 27, 28, 29, 30.
Everybody clear? We're shocking. Back on CPR. Count out for me, Joy.
10.
Okay, good CPR.
20.
How's your compliance, Pat?
It's good.
Okay, make sure you're coming off the chest.
All right. 30.
Good job.
ALS will show up. Hey, Les, how you doing?
Shane, how's it going?
Good.
We've got a 65-year-old witness cardiac arrest. Went down about 5 minutes ago. It took us about 3 minutes to get on scene. No CPR prior to our arrival. We've shocked him once. And we're at 80 compressions right now.
Okay, Les, can you let me know when we get to 200?
Okay, we've got about another minute.
Okay. So I switched
Airway's
over.
good.
Awesome. So I've switched over. They're using a LifePak 500, so it's compatible with the LifePak 15. All I got to do is unplug the AED
So much you
and
care
plug
about
in the
that.
LifePak 15. I have a lot of time now.
110.
I don't want to mess up their
Good job,
triangle of
George.
life, so let's start working on my IO, or my vascular access. Since I just have it done, it's pretty simple. I have all the time in the world. My EMT is spiking me a bag and getting my drugs ready for me. So I'm still working on my IV. I'm still listening to see what number they're on.
We're 150.
We're on 150. Wonderful.
60.
Since I don't know what's on the screen because they're doing really good CPR, okay? My end tidal, I can see
180.
is at 35. Okay? Well, we're going to keep going to 200. I'm going to charge the monitor at
91,
200, guys.
92, 93, 94,
Read-
95,
keep going,
96,
Joe, keep going.
97, 98, 99, 200.
200. Charging the monitor, 200 joules. Remember to switch after I shock, okay?
Okay, are we clear?
Okay, and clear the chest. We're in VFib, shocking. Shock delivered, switch. Thank you. All right. Now I have all the time in the world, okay? CPR, the PIC crew, the triangle of life is dialed. Now I have 2 minutes, okay? I can think about my H's and T's. I can think about giving a medication, the right medication, okay? Now I can talk to family. So was this a witness arrest? Were you doing CPR? What happened? Okay? Again, I have 2 minutes. How's my airway, Les?
9.
We got a good airway.
Good. Okay?
Compliance.
They're their own separate entity. Okay? The leader is Les. If I just communicate with Les, that's my single point of contact. My EMT, again, is just assisting me at this time. But if Joey is tired, if it's at 15 minutes and Joey is tired, my EMT partner can switch in with Joey. Okay? The last thing on the list is airway. If you just want to take the airway completely away, you can for a couple seconds. It's not a big deal. Okay? But this, essentially, is PIC resuscitation.
9, 10. 10.
Last we have 130.
130.
9, 10.
Good job, you guys.
9, 10. 9, 10. 9, 10. 9, 10. How's my dad?
Yep, that's good. Recoil's good.
9, 10.
Shane, we're coming up on 200.
Wonderful. I'm going to charge them on right to 200. Keep going, and then we'll go from there.
We're at 2.
200. Charging them 100. Keep going.
10.
Stand clear of the chest.
10.
Off the chest. Check pulse. Doesn't matter. Ready cardiac. Go back to CPR. Okay. We jump the charge right away. I don't want to have a loaded gun with my finger on the trigger. So I want to dump the charge as fast as I can to check a pulse. Either do so or not.
10, 30.
About half that much air, Cat.
9, 10, 40.
Let's fast forward to 180.
80.
We're at 180.
Good. Again at 200. I'm going to
90,
charge the
91,
monitor.
92, 93, 94, 95, 96, 97, 98, 99,
200.
200.
Keep going, Joey. Stand clear.
Clear.
Check pulse. Good strong pulse. Blood pressure, 12 lead. Okay. We'll call the hospital. Okay.
Fire department? Yes, hi guys. My dad, he's unconscious.
Sir, how long has he been down?
He just went to hospital about a minute ago.
A minute ago?
He was complaining about chest pain.
Just before he passed
yeah.
out? You didn't do any CPR?
No, he just passed out like right now.
Okay.
6, 7.
How old is he?
He's 55.
Okay, what kind of medical history you got?
He had a heart attack about 2 years ago.
Okay.
High blood pressure.
Any diabetes?
Diabetes.
4, 5, 6.
That's about it. Just those 3 things.
Okay.
10. 14, 15,
Hey, down there, Mike.
17, 18, 19, 20.
Okay.
5, 6, 7, 8,
Here, Mike.
9, 30. 3, 4, 5, 6, 7, 8, 9.
I'm clear?
Shock advised.
Okay, let's get 30 compressions in, then we'll shock.
5, 6, 7,
Good job, Mike. How's your compliance?
14, 15, 16, 17, 18, 19, 20,
Little puff, little puff.
9, 30.
Stand clear, shock. Okay, let's get back on the chest. Start CPR again. Okay, I'm going to get an OPA in. OPA in. Sir, can you gather up his medicines for me?
Yes, I'll gather them right
Thank
now.
you. And we'll have the medics coming in, so they'll be coming in the house here in a second. Good job, Mike. All right. We're 30 seconds into it. Good job, Mike. Good. 1 minute. Good job.
Compression.
30 seconds left. Looks good, Mike.
9, 5, 6, 7, 8, 200.
20 seconds left. We need to analyze. Okay.
Thank you.
Good. 10 seconds. Okay, we're going to switch after this, after you analyze. Okay, we're going to switch. Stand clear.
Clear. Analyzing now. Stand clear. Shock
Okay,
advised.
let's do 30 compressions and we'll shock.
4, 5, 6, 7, 8, 9, 10, 13, 14, 15, 16, 17, 18, 19, 20,
10 more, then we'll shock.
4, 5, 6, 7, 8, 9, 30.
Everyone off, stand clear. Shocking. Continue CPR.
3, 4, 5, 6, 7, 8, 10.
Hey, Mark. Hey, Shane, I have a 54-year-old witness arrest, no CPR prior to arrival. He did have a heart attack 2 years ago.
6, 7, 8,
Family member says that he does have high blood pressure and he's a diabetic. We have 2 previous shocks prior to your arrival. And we're working on our 23rd round of compressions. We're on 20, so you have about a minute 40 left.
Okay, keep counting on the compressions for me. I'm going to work on my IO since we have so much time.
Okay, and I do have an OPA in place.
Wonderful. Mike, how's the compliance on the way? Good. Okay, we're making sure we're giving 100 cc's, which is great. I see that, Mike. Good job.
Robert, good job. Mike, good job.
4, 5, 6, 7, 8, 9, 10.
Checking my line, all that good stuff. Excellent.
14, 15, 16, 17,
Mimicking
18,
the IO.
19, 20. 3, 4, 5, 6,
Got lots of time.
8, 9, 10. 13, 14.
Okay, Shane, we're just entering 1 minute of compression.
19, 20.
Awesome. Just keep the count for the me, Mark. That'd be appreciative.
Okay,
7,
a little bit deeper, Robert.
30.
Good.
3,
Still working on my IO.
6, 7, 8, 9, 10. 13, 14, 15, 16, 17.
Hey, Mark, if you can let me know when we get around 150.
Yeah.
Because I'm kind of busy.
5, 6, 7, 8, 9, 30.
We're right at 160 now, Shane. 160.
Excellent. So we're going to keep going past 200. So just keep
70.
going. We're going to start charging at 200. So let me know when we get to 200.
20. 180.
Good. Keep going. Looks great, guys.
10.
190.
20.
200.
Good. I want to reminding of charging. I'm not going to shock you guys. We're charging 200. Remember to switch rescuers after I stop you.
5, 6, 7, 8, 9.
Go ahead and hold compression. We're in VFib shocking. Shock delivered. Back to the chest knee rescuer. Excellent job.
Good job, Mike.
Nice work. Red, ready? Mark, you said family's around?
Family's right over there. It's his son.
Just let me know when we get to 150. I'll be back.
Good job. How you doing, Mike? All right. All right. Where you at, Mike? 100? Okay.
10.
A little deeper, Mike. There you go. Right there. Shane, we're at 140.
Thanks, Mark. Make my way over to the monitor. Again, we're going to keep going past 200. I'm going to start charging at 200. And then remember to switch after I stop you guys.
70.
170.
Nice work. Nice work.
80.
180.
90.
Okay, Shane, we're hitting 200 right
Okay.
200.
now.
Charging monitor. Remember to switch after I stop you.
10.
Go ahead and clear.
Okay, let's switch, guys.
VFib, shocking. Shock delivered, switch rescuers. Nice work.